A patient enters a hospital with no idea that anything serious is wrong. The scan looks almost normal, but before the doctor opens the file, an artificial intelligence system has already marked one tiny region in red. It could be harmless. It could also be the earliest warning of a dangerous disease. The AI does not deliver the final diagnosis. It does something more realistic and potentially more valuable. It tells the human doctor where to look. This is the real story of China's medical AI revolution. Not a robot replacing every physician, not a machine that has defeated all human doctors, but a country moving AI into hospital workflows faster and at greater scale than many observers expected. DeepSeek models are being connected to patient service platforms, medical records, report interpretation, research tools, and clinical decision support. Specialized algorithms are assisting with medical images. Virtual hospitals are training AI agents before they encounter real patients. And China's health authorities have created formal guidance for using artificial intelligence across medical services and hospital management. The transformation is real, but so are the exaggerations. And when healthcare is involved, confusing a brilliant benchmark score with safe clinical practice can be dangerous. Today, we are investigating what China's AI hospital systems can actually do, what DeepSeek's medical performance really means, and why the future may not be AI replacing doctors, but doctors becoming far more powerful with AI beside them. Subscribe for more premium documentaries about China's technology and the innovations reshaping the world. Now let us return to that patient. The doctor opens the scan. A conventional medical image contains an extraordinary amount of information. A human specialist may examine hundreds of slices from a CT scan, looking for differences in shape, density, and structure. The work requires expertise, concentration, and time. An AI imaging system can analyze those images rapidly. It can compare patterns with examples encountered during training. It can highlight areas that deserve attention. But the word highlight is important. The algorithm does not know the patient as a person. It may not understand that the patient recently had an infection. It may not know that a previous surgery changed the anatomy. It may not recognize that a scan contains an unusual artifact. The physician combines the AI alert with medical history, examination, laboratory results, and professional judgment. That is the hybrid model now emerging in China. The AI searches, the doctor interprets. The AI summarizes, the doctor decides. The AI can operate continuously. The doctor remains responsible for the patient. This partnership extends far beyond diagnosis. Imagine a busy outpatient consultation. The patient describes several symptoms, sometimes in an uncertain order. The physician asks questions while examining previous results. Traditionally, the doctor must divide attention between the patient and the computer. They type notes, they select codes, they search through records, they complete administrative forms. A clinical language system can listen, with appropriate consent and privacy controls, then prepare a structured draft. It may organize the symptoms, identify relevant medical history, suggest possible missing questions, draft the consultation note, prepare a patient-friendly explanation. The physician reviews and corrects the output before it enters the official record. That does not look as dramatic as a robotic doctor, but reducing administrative work may be one of AI's most immediate healthcare benefits. Every minute saved from repetitive documentation can become another minute spent listening to the patient. Chinese hospitals have reported integrating DeepSeek into functions such as medical record assistance, report interpretation, research, pre-consultation services, and hospital operations. In Yiwu, for example, a hospital connected DeepSeek to outpatient and inpatient systems, and later introduced AI-assisted translation of medical examination reports. A Shanghai hospital reported using the model for management while planning wider applications such as pre-consultation, report explanation, record quality control, and research. These are meaningful deployments, but notice what they are not. They are not evidence that DeepSeek independently treats patients without physicians. DeepSeek is a general reasoning language model. It can be adapted to medical workflows, but it is not automatically a certified medical device simply because a hospital installs it behind its firewall. The hospital must control what information it can access. It must determine which tasks it can perform. It must ensure doctors review high-risk output. It must protect patient data. And it must monitor errors. This distinction disappears in many viral headlines. A hospital using DeepSeek could mean an internal research assistant. It could mean document summarization. It could mean patient report translation. It could mean support for clinical decisions. Those applications carry very different levels of risk. Correctly translating a report is important. Recommending a medication is much more dangerous. The higher the clinical risk, the stronger the evidence and supervision must become. So why are people claiming that Chinese AI has outperformed every doctor? The answer comes from benchmarks. DeepSeek R1 has demonstrated powerful medical reasoning on written questions. In one published comparison, using US MLE-style material, the model achieved 92.5% overall accuracy and exceeded the reported average performance of human examinees across the tested steps. That is a serious result. But what does it prove? It proves that the model can answer many structured medical questions correctly. It suggests that the model has absorbed a large amount of medical knowledge. It shows that advanced reasoning systems may become valuable educational and decision support tools. It does not prove that the model is the best doctor on Earth. A licensing examination presents the information required to solve the problem. The real patient rarely does. Patients forget details. Symptoms change. Test results conflict. Rare diseases resemble common ones. Common diseases occasionally appear in unusual ways. Some patients cannot communicate clearly. Others have multiple conditions and medications interacting at once. A physician must decide which information is missing before deciding what the information means. A model may produce an excellent answer when the question is carefully written. Clinical medicine begins before the correct question has been identified. There is another problem. Language models can sound confident even when they are wrong. This is sometimes described as hallucination, but in medicine, the consequences are more serious than an invented historical date. A fabricated drug interaction can cause harm. A missed emergency symptom can delay treatment. A false reassurance can send a sick patient home. Stanford's 2026 AI Index highlights that leading models can still perform poorly when prompts contain misleading beliefs or adversarial framing. In one Stanford-linked cardiovascular experiment, DeepSeek R1 produced inappropriate responses to all prompts that explicitly encouraged inaccurate information. This does not make the model useless. It shows why supervision matters. A doctor knows that a patient asking for antibiotics may not need antibiotics. An AI trained to be helpful may be tempted to satisfy the request. Safe medical systems must be designed to resist pressure, recognize uncertainty, and escalate difficult cases. They need more than intelligence. They need boundaries. China's advantage is that it is not approaching medical AI as one isolated application. In November 2024, the National Health Commission and other agencies published reference guidance covering a broad range of healthcare AI scenarios. These include imaging support, clinical services, patient management, public health, traditional medicine, research, and operational management. That policy direction matters. Hospitals know that AI integration is not merely a short-term technology trend. It is part of a national strategy. Local governments, technology companies, and medical institutions can build around that direction. Systems can be installed within hospital networks. Models can be adapted to local workflows. Hospitals can experiment with patient services, research tools, and administrative automation. China also has an enormous healthcare workload. Official statistics show more than 10 billion medical visits during 2025. Even modest improvements in efficiency can therefore affect millions of encounters. Suppose AI saves only 2 minutes of documentation per consultation. Across millions of consultations, that becomes an enormous amount of clinical time. Suppose an imaging tool helps prioritize the most suspicious scans. That may allow urgent patients to receive attention sooner. Suppose a rural clinic can obtain decision support from a system trained on specialist knowledge. That may improve access where human specialists are scarce. This is where AI could create its greatest value, not by replacing the world's most experienced surgeon, by spreading part of specialist knowledge to places that do not have enough specialists. China's Agent Hospital project explores another part of this future. Developed by researchers at Tsinghua University, it is a virtual environment in which AI agents play the roles of patients, nurses, and doctors. The system simulates the care process from the onset of illness through triage, consultation, diagnosis, treatment, rehabilitation, and follow-up. This is not the same as opening a public hospital staffed only by artificial doctors. It is closer to a training ground. An AI physician can encounter thousands of simulated patients. Researchers can observe its mistakes. They can alter the system. They can test unusual cases without risking a real person. That could become an important method for improving medical agents. Airline pilots train in simulators because rare emergencies are too dangerous to practice for the first time in a real aircraft. AI medical systems may need a similar environment. Before an algorithm is allowed to influence real treatment, it should encounter difficult virtual patients, patients with incomplete information, patients with multiple illnesses, patients who describe symptoms incorrectly, patients who react badly to standard treatment. The goal is not to prove that the AI never fails. It is to discover how it fails before those failures reach the public. But simulation has limitations. A virtual patient behaves according to rules created by researchers. Real human beings are less predictable. A system performing well inside a simulation may struggle in a crowded rural clinic, an emergency department, or a hospital with incomplete records. That is why clinical evidence must move through stages: benchmark testing, simulation, retrospective review of previous cases, prospective trials, supervised deployment, continuous monitoring. The faster a country deploys AI, the more important this safety ladder becomes. China's speed can be an advantage. It can also magnify mistakes. An error inside one pilot program affects a limited group. The same error embedded in hundreds of institutions could spread rapidly. Scale multiplies benefits. Scale also multiplies risk. Then there is privacy. Medical records contain some of the most sensitive information a person possesses. Diagnoses, genetic risks, mental health history, medications, pregnancy information, family history. Hospitals using locally deployed models may keep data inside internal systems rather than sending it to an external public chatbot. That can reduce certain privacy risks. But local deployment does not remove every threat. Who can access the system? Are prompts recorded? Can data be used to retrain models? Could an attacker extract patient information? Are employees properly restricted? Can patients opt out? AI healthcare is also a cybersecurity challenge. A fast hospital is not a safe hospital if patient records can be exposed or manipulated. Another unresolved issue is responsibility. Suppose an AI flags a scan as normal. The doctor accepts the recommendation. Months later, the patient learns that a tumor was visible. Who is responsible? The physician? The hospital? The software developer? The company that supplied the model? The team that adapted it? The regulator that allowed its use? Healthcare systems need clear answers before AI moves from assistance to authority. This is why the future is unlikely to involve one universal AI doctor. Medicine is too specialized. A model assisting a radiologist needs different evidence from one supporting mental health care. A pathology tool analyzes images differently from a language model summarizing records. An emergency triage system must value sensitivity differently from a routine administrative assistant. The future hospital may use dozens of specialized AI systems rather than one digital physician controlling everything. One system schedules resources, another drafts notes, another analyses images, another checks medications, another follows chronic disease patients at home. The human medical team connects those pieces, and this may be where China's approach becomes globally important. The country is creating enough real-world deployments to reveal which applications provide genuine value and which create more problems than they solve. Other countries should neither dismiss China's progress nor repeat its systems blindly. They should study the outcomes. Did waiting times fall? Did doctors spend more time with patients? Were cancers detected earlier? Did unnecessary tests increase? Did poorer regions benefit? Were certain groups misdiagnosed more often? Did costs fall? Those questions matter more than which model wins a written examination. The most advanced healthcare system will not be the one with the most impressive AI demonstration. It will be the one that improves patient outcomes without sacrificing trust, privacy, or accountability. Imagine our patient again. The AI highlights the suspicious area. The physician examines it. A second test is ordered. The condition is discovered early. Treatment begins before symptoms become severe. In that moment, it does not matter whether the AI or doctor deserves more credit. The patient is alive because they work together. That is the future worth building. Not artificial intelligence replacing human care. Artificial intelligence removing blind spots, reducing repetitive work, and extending expertise, while trained professionals remain responsible for judgment and compassion. China has not built a machine that outperforms every doctor on Earth. It may be building something more realistic and more powerful. A healthcare system in which every doctor can consult a tireless second pair of digital eyes. Whether that becomes a medical revolution or a dangerous experiment will depend on the rules, evidence, and human supervision surrounding it. Subscribe for more documentaries about China's technological transformation. And tell us below, would you trust AI to provide a second opinion if your human doctor still made the final decision?